kidney, and how do we filter that blood once we reach the glomerulus. Okay, guys? Now, what happens inside the kidney? In order to understand what happens and how do we filter, you guys need to know that your kidney is divided into cortex outside and medulla down. So once you have the renal corpuscles, it means you are in the cortex. So this is your cortex and this is your medulla. The medulla, you guys, have your tubular system, and the cortex, it has your renal corpuscle. What is renal corpuscle? It's basically, you guys have your blood, the very smallest blood that is ready to get filtered. It forms a tuft of capillaries. Tuft of capillaries looks like woolen, these filaments, or a wool tuft of capillary, and the blood capillaries, that way they will form this capillary network, and that tuft of capillary is gonna push against a closed serous sac, just exactly like the peritoneum and the pleural cavity, which is what we call the Bowman's capsule. The Bowman's capsule is as a membrane, and once you push against them, you will have two layers, okay? So you will have a visceral layer that surrounds your capillaries, and you will have a parietal layer that is at the wall outside. The parietal layer is going to be away from you, and the visceral layer is going to be at a contact with your blood capillaries. And here we will have the filtration. It's going to happen here. And we're going to talk about the visceral layer as we proceed to understand the cells of this visceral layer and how does the filtration happen. Now, the whole thing, you guys, we call it renal corpuscle. Okay, and this fashion of this tuft of capillary is what we call the glomerulus. Okay, so the red thing here is what we call the glomerulus, which is number 1. Okay, so this is number 1 is the glomerulus, and the whole thing is what we call the renal corpuscle, and the two layers of the blue is what we call the Bowman's capsule. So once the glomerulus comes with the Bowman's capsule, we call it renal corpuscle, and here is what we're gonna happen. The filtration is gonna happen. The blood will come in, it will get filtered. We will take the filtrate. The filtrate will go through the tubular system, and then the blood comes out filtered to the vein back. And then once we get the filtrate, it needs to go through the proximal convoluted tubule, and then proximal straight, and then the loop of Henle, and then you have the distal straight, and then distal convoluted, and then the collecting all the way down, and that collecting is gonna open into a bulging part of my pyramid, or the pyramids, or the medulla, and that is what we call the renal sinus. And from here you're gonna collect that by the calyces and take it all the way to the ureter to drain it outside of the body to the urinary bladder. So here you have the corpuscles, renal corpuscles. If you are very far away at the beginning of the cortex, and this is of course outside is the capsule of your kidney. If you are very far away, this is what we call the cortical nephrons. Okay, we have the cortical ones. The whole thing is what we call nephron, you guys. Okay, the whole thing, we call it nephron. Now, if you are here, it's cortical. If you are very near to the medulla, we call it juxtamedullary nephrons. All right. So what does juxta mean? Juxta means you are neighboring to the medulla. So I have here an arrow, but yeah, the yellow arrow. So what happens is basically we have something called medullary rays. Medullary rays is basically your straight tubules. So you have proximal convoluted and you have distal convoluted, forget about them. You have a straight proximal straight, you have distal straight, and you have the loop of Henle, and you have the collecting duct. All of these are straight tubules. If you look at them here, they will give you something that looks like rays. Okay, looks like sun rays or any rays. So once they run here in the cortex, these tubules, all the straight tubules, we call them medullary rays. Why do we call them medullary rays? Because they are rays that are trying to reach the medulla. Because once we reach the medulla here, we're ready to open into the, by the renal sinus, we are ready to filter, to take this filtrate into the calyces and then the renal pelvis and then to the ureter. Okay, so that part here we call it medulla. So the things that are trying to reach the medulla, we call them medullary rays, although they lie in the cortex itself. So this is cortex, but the tubules, the straight tubules, proximal straight, distal straight, the lobe of Henle and collecting, they lie in the cortex, and they are collecting each other's here to bring all the filtrate all the way to the renal sinus, and from there you take it there. So they are lying in the cortex. That's why we call them medullary rays. It doesn't mean that they lie in the medulla. They are trying to reach the medulla. Okay, guys? Now here is the idea of the glomerulus, like I told you guys. What happens is your blood capillary is like your hand that is getting into a sleeve. So guys, the sleeve, the tissue of the sleeve is basically the visceral layer of the Bowman's capsule. And your hand is basically the blood vessel. So the blood is coming in your hand, and then you are trying to filter that out of your hand, okay, because you want to filter the blood. So the filtrate will come outside. So once it comes outside, it will come in the renal, in the urinary space, and then it's gonna be collected by the proximal convoluted tubule. Okay, so you are going to filter that blood, but I just want you to understand that your arm is the blood capillary, it's the glomerulus itself, and the sleeve outside is basically the visceral layer of Bowman's capsule. And we're gonna talk about the cells, I think, in the next slide. But what happens here is, if the blood is coming into your arm here, okay, by the filter is gonna be, so the filter paper is gonna basically be your sleeves that wants to take this filtrate outside into the urinary space. And once you collect it, you will take that all the way to the tubular system, and then your arm will take it back into the blood. Afferent comes in and efferent goes out. Okay, so just understand that the sleeve is the tissue of the visceral layer of the Bowman's capsule. Okay, because the visceral layer cells, you guys, is gonna be your podocytes. And we're gonna talk about that as we proceed. So if you guys look at the sleeve, now I'm sure everyone can imagine how the story is happening here. Your arm is basically, try to imagine that this is your arm, this is your blood vessel that is having fenestrated capillaries, fenestrated because we have those fenestrations that will help us to take stuff out of the blood that we want to filter. And thanks to the cells of my sleeve that I'm wearing right now, which is my visceral layer of Bowman's capsule, the cells of the visceral layer of Bowman's capsule is what we call podocytes. So the podocytes is basically like a hand that has fingers, and these fingers are what we call the pedicel. So the pedicels are those finger-like projections of the cells of the visceral layer of Bowman's capsule that is going to help to wrap around the blood capillaries and try to decide what exactly needs to get filtered out of the filtration slits and what should not be filtered. Okay, so the big proteins of blood should not come out of the capillary, like the blood albumin and the important proteins, large sized proteins should not come out of the blood. So this is ensured by the blood-renal barrier that is formed by the pedicels of the podocytes. It will give you filtration slits that will be specific on what exactly should come out of the fenestrations to the urinary space here and what should not come out of it. So moving on, what basically happens is the blood comes in by the afferent arteriole, it runs in the glomerulus, the podocytes are sitting on top of it, closing off those fenestrations and making sure that not everything comes out of them, and what is permitted to come out will come out. And once they come out and they get into the proximal convoluted tubule and they run into the tubular system, we have blood capillaries that are wrapping around to reabsorb. All right, so we will have things that will reabsorb. Not everything will be coming out and filtered. Pretubular for the cortical nephrons, but the vasa recta for the juxtamedullary ones. All right, remember that. And once we reabsorb and we finish our filtration, it will get back into the renal vein, into the circulation. So basically, you have your blood capillary, you have your fused basal lamina between your basement membrane of the capillary and the basement membrane of the podocytes, because you guys, once you want to do the function of that organ, of any organ of your body, even the lungs, even whatever organ you have, once you want to do a function, the simplest cell of the blood needs to meet with the simplest cell of your organ, and then the basal lamina that the cell is lying on should unite and fuse with the basal lamina of the blood side. They should fuse together so that you can do the function, you can exchange stuff between us. If we are in the lung, we are exchanging gases. If we are in kidney, we are exchanging filtrates. Not everything should get out of your blood, okay? Only small molecules, only some vitamins. Most of the vitamins should not get filtered, and they will come back to the blood by the peritubular capillaries or vasa recta. Some of them will get filtered, and also the solutes and stuff like that. You're going to take that in physiology. And so once you have a cell, the endothelial cell from your blood capillary side, and once you have your simplest cell from the podocyte, in case of kidney, your basal lamina that your cell is lying on is going to fuse with the other one together, and that way here you can exchange the molecules between your blood and your organ itself. All right, guys? Now what happens here is that you will have your blood coming in, all right, and then the glomerulus will be here, and then you will have the efferent arteriole coming out. There is a very important structure here, you guys, called macula densa. And macula densa are densely packed cells. That's why we call them macula densa. And these cells are in the distal convoluted tubule. These cells are very important because they will detect if there is a low sodium level and low blood pressure level. Once they will detect that, I would like to explain it in I have another diagram. It's better than this. And I would like to explain that on that diagram. Okay, so let's go to the diagram and explain the idea of the juxtaglomerular apparatus. I just want you guys to see that for when I talked about the fused basal lamina, I said that we have blood capillaries in the glomerulus, and we have our visceral layer of Bowman's capsule that is like here. It's kind of covering the blood capillary, and you will see that these lines, small lines, are the processes, the pedicels of your podocytes. Okay, so the podocyte is running here, and you have the small pedicels all the way sealing off spaces between them to do the filtration barrier and to decide what exactly that should be filtered. All right. I want to tell you one thing about an important cell. So if you guys have your podocytes forming the tissue in the tissue in the sleeves that is covering your blood capillary, you're going to have spaces in between them, and these spaces should not be left without any support. So we have something called mesangial cells. We have something called extraglomerular mesangial cells, And these, thanks to these cells, because they need to support, because whenever you don't have podocyte, you need to have a support by cells that fill in the spaces between them to support these cells. And they also have immune function, and they also do a phagocytic function. So these mesangial cells, we call them extraglomerular. All right, so extraglomerular, it's outside the glomerulus, and they are supportive cells, and they are completing the tissue that wraps around the blood capillaries. Okay, so these are the extraglomerular mesangial cells. Okay, so and today we have the number X mentioned 3 times. We have juxtamedullary nephrons, not cortical. The juxtamedullary nephrons, these are the nephrons that are lying neighboring to the medulla, but in cortex, of course, because all the nephrons are in the cortex. We have extraglomerular mesangial cells, because they are outside the glomerulus. And you have something called juxtaglomerular cells. We're going to talk about the juxtaglomerular cells in a bit, but they are very important, and these are the most important out of everything. Of course, the other cells are important, but I'm just trying to tell you the names of the confusing names together so that you can remember how to differentiate between those silly names, okay? And they make sense because juxta means neighboring and extra means outside, all right? Now, the last confusing cell is what we call the juxtaglomerular cell. The juxtaglomerular cell, guys, it's an apparatus, and that apparatus as a whole is very important in maintaining blood pressure and sensing low sodium levels in blood. So what's going to happen is we will have the afferent arterioles bringing the blood to the glomerulus, and then you have the efferent arterioles, all right, coming out of the glomerulus. So we will have a densely packed cells in the distal convoluted tubule that they have the ability to sense if there is any change in the blood in the sodium level and blood pressure. If it's low, they will be activated, and once they are activated, they will activate the where is the juxtaglomerular cells. Okay, so you will have the juxtaglomerular cells. They will activate the juxtaglomerular cells of the capillaries, and we call them juxtaglomerular because they are neighboring to the glomerulus. In a bit you will reach the glomerulus, so you are neighboring to them, exactly like when we said the juxtamedullary nephrons. Okay, you are all about to reach the medulla outside in the kidney. So these are what we call the juxtaglomerular cells. These cells are modified smooth muscles in your capillaries that are going to form the glomerulus. And once the macula densa sense that there is low sodium levels, it's going to activate those cells. And once you activate the cells, these cells will secrete renin. And of course, you guys know that once you activate the renin from the kidney, it will go all the way to convert angiotensinogen in the liver into angiotensin 1. This is what we call the RAS system, RAAS system. You will convert angiotensin 1 into and angiotensinogen into angiotensin 1. And by enzyme, the ACE, angiotensin converting enzyme, by the lungs and heart, you will convert 1 into 2. And once you convert it into 2, it will activate your adrenal gland to secrete the aldosterone, and aldosterone will go ahead to the renal tubules to reabsorb sodium and bring it back. And once you bring it back, the sodium to the blood, you will increase the blood pressure in your blood. All right. So this is just a quick revision about the RAS system. So the macula densa, it can sense the sodium levels in the distal convoluted tubules. These are densely packed cells that is facing, it's part of the apparatus, And once you feel that, you will activate the juxtaglomerular cells, and that will secrete renin, and you will have the whole story, and then you come back to the tubules to reabsorb sodium. And remember that I told you guys the mesengium is basically the matrix that wants to support the podocytes of your visceral convoluted of your visceral what did I just say? It will support the podocytes of the visceral layer of the Bowman's capsule. And of course, these are the podocytes, the blue ones, and these are the processes coming out of them, the pedicels, that is closing off fenestrations and making sure that not everything gets filtered of the blood to the urinary space. Okay, so the mesengial cells, the extraglomerular mesengial cells are basically supportive with, like I said, immune function, phagocytic function, but the main thing is basically they really need to support all these cells in the tissue that wraps around your glomerulus. And once you get the urine into the urinary space, this is the vascular pole, because the blood comes in here and comes out here, and this is the urinary pole. And once you get the filtrate out of this, it will get into the proximal convoluted tubule. And once you get it out of the proximal, you will go all the way in the tubular system, and then you will collect it by the collecting tubule. And from there, of course, you have your pyramid. You have the bulging part is what we call the renal sinus. And from the renal sinus, you will collect it by the minor calyx, minor calyces. Minor calyces will 3 or 2 together, they will form the major, and the major calyx, one with another one with a third one, will form the renal pelvis, and from the renal pelvis you will form the ureter, coming all the way, taking the filtrate into the urinary bladder. And we're going to talk about even as we proceed. So once you have your blood, we talked about the blood and how we filter the blood, and once you get it, it will come into the tubular system. The very first part of the tubular system is your proximal convoluted tubule. As you guys know, this is the glomerulus. You just here formed your filtrate. It will go through the proximal, and from the proximal you go all the way into the proximal straight, and then lobe of Henle, and then you have the distal, and then from the distal to the collecting all the way to the renal sinus here, from the renal sinus to the calyces, and then pelvis, and so on. So we need to see these histologically, and these are cuboidal cells. 3 of them are cuboidal cells. The proximal ones are bigger in size. They are more acidophilic cytoplasm. They have brush borders. They have smaller lumen because the cells are packed, all right? And the distal is smaller than them. The size is smaller. The acidophilic cytoplasm is less. They have larger lumen because they don't have brush borders. And the collecting tubule is more or less looks like the distal, but they have basolateral foldings that as if you are drawing the cells with your hands. And I'm going to tell you now how to differentiate between them, but all of them are cuboidal cells. So if you look at a histological section, you will see that you have a tubule in the kidney. Of course, they will give you a low magnification to tell you that you are here in the kidney. So once you see that you are having more acidophilic, smaller lumen, occupied by brush borders, this is going to be your proximal. Look at the brush border. You cannot see the white area of your lumen because it's occupied by brush border, and it has acidophilic cytoplasm, bigger sizes of the cells, puffier cells. So this is proximal convoluted tubules. And if you look at the one that is having less acidophilic, you can see white space inside, smaller cells. This is going to be the distal. Now, what about the collecting? Look, you guys, at the basolateral foldings, as if I wrote, can you see the cells? Can you see the borders of the cells? As if it's a cell next to a cell, next to a cell. Can you guys see the lines between the cells? These are all lines. So that will give me a hint that this is a collecting duct, not distal convoluted tubule. Can you guys see here? These are all the lines between your cells. It means this is basically your collecting duct. But if you look at one that you cannot see lines between the cells, and you can still see a large lumen, less acidophilic, smaller cells, this is distal convoluted tubule. Okay, so this is how to differentiate between the collecting and the distal. Okay, you can see lines between the cells. If I removed everything here, you can see the lines between the cells. You can still see the lumen, all right, it's larger in size. Okay, this is collecting. If I can see the lumen, but the cells are, I cannot see borders between the cells and they are smaller in size, this is distal. If I cannot see a lumen, it's not white, it has brush borders inside, occupied by the brush border, bigger cells, more acidophilic, no lines between the cells, this is proximal. Can you guys see? Proximal, 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 proximal. Bigger cells, more acidophilic, occupied by brush borders for more absorption. Okay, and the main function of the proximal is to reabsorb water and glucose, and the main function of the distal is to reabsorb sodium. All right, and the main function of collecting is to reabsorb potassium, and of course more function of that should be explained in physiology. Okay guys, so now you know how to differentiate between the three types of tubules. Now, how the urine will flow, like I said, guys, starting from the glomerulus, it's gonna go all the way to the tubular system that we talked about. And from the tubules, you have something called renal sinus. So you guys, can you see this? What I'm doing in blue? Can you guys see? This is what we call the renal sinus. It means you're ready here. Can you guys see this? Okay, can you guys see this? These are renal sinuses. So you get the urine all the way to the calyces. So one from here, all right? So one from, hold on. So this is a minor, and this is a minor, this is minor. Together they will form major calyx. Okay, so this is one major, and this is another major. Major calyces together will do the renal pelvis. Once you do the pelvis, you will go all the way to the ureters to drain into the urinary bladder. So if you want to try to see it in a real kidney, you have your renal pyramids or medulla, and then you have, once you come out of the medulla, you are in the minor and minor. Once you are a union of couple of minors, this is the major. Once you come out of the major and major and major, and here you will try to form your renal pelvis. So once you are a major and another major and another, and you're going all the way to the ureter, the widest area before your ureter is gonna be the pelvis. Okay, so again, if you are small and near to the medulla, this is minor. If you are big and union of this minor with this minor with this minor, this is major. If you are here and you want to go all the way to the ureter, this is your renal pelvis. Okay. Now, how is the orientation of the hilum of the kidney, you guys? If you look at the kidney, you guys, you will find that the hilum, which means the structure that pass through the kidney in and out, which is basically your renal artery, renal vein, and renal pelvis, are arranged anterior to posterior as renal vein. Vein comes first, and then the artery comes next, and then the pelvis. Why is that? Because you guys, the vein has a collapsible or collapsed lumen. I cannot have the vein at the back because the structures in the front can compress and prevent venous drainage. So the vein, which has the weakest wall, is going to be anterior. And then the pelvis, because it has a strong muscular wall, it's going to be the posterior most structure because it can resist the pressure that comes from these two structures. And then the artery, because it's pulsatile, it changes its pressure, it's going to be in the center. Okay, so it makes sense that the vein comes most anteriorly. Okay, so the renal vein comes most anteriorly, followed by the artery, and then the renal pelvis is most posterior structure. And don't say why this is anterior, this is not, this section is not made in a straight plane. This is just for demonstration, but if you guys go ahead and hold a real kidney, you will find that the vein comes first, followed by the artery, and then the pelvis is most posterior structure. So vein, artery, and then renal pelvis. Okay? Now what happens here, we have the ureters, and the ureters have a length of 25 centimeters. So remember that 25 is the magic number for renal system. 2.5 was the thickness of the kidney, 5 was the width of the kidney, 10 was the length, and the length of the ureter is 25 centimeters. It extends all the way from the pelviureteric junction at the level of L2 all the way to the urinary bladders. It's only one. Okay, and it's crossed by important structures in the pelvis. It's a concept called water under the bridge concept. It's crossed by the vas deferens in male and uterine artery in female, and it's very important that during ligation of one of these two structures in male or female, we should not get confused between them and the ureter, because you will have a problem with the renal system. And more details about the idea of the water under the bridge is actually explained in the reproductive module playlist. So I'm not gonna explain that in here. You guys, if you need to know more about that, you can go ahead and watch those videos. Now what happens in the ureter? You guys, in the ureter, as the ureter comes from the kidney all the way to the ureter, to the urinary bladder, you are going to have a sphincter at the beginning and a sphincter at the end. The beginning one is going to be at the pelviureteric junction, because you want to prevent backflow of the urine into the kidney, and the other one is going to be in the intramural part as you enter the urinary bladder, because you don't want, when you want to empty the urinary bladder, you don't want the urine to backflow into the ureters. Okay, so so at these two you have sphincters, so these are constricted, anatomically constricted areas in the ureter. Why it's important to know about the constriction? Because these are the areas you would expect to find stones, of the kidney stones. So it's important to know that at the level of L2, this is the first sphincter you have at the pelviureteric junction. So you would expect to see kidney stone at that point. And also in the intramural part, inside, when you are entering and running in the thickness of the urinary bladder, you have the other sphincter, and you would expect to find stones here. And then you have two other constricted areas, and these constrictions are because the ureters want to run with the flow of the pelvis. So at the bifurcation of common iliac into internal and external iliac, you have a kink. You have a back side running of your ureter. It wants to run back with the pelvic contour to get into the pelvis. So at this point, at the sacroiliac joint point, you would expect also to find a kidney stone, because this is a constricted area. So if I have a stone, it will get lodged here. So this is a kink, or narrowing, anatomical normal narrowing, that is important that we know. We might find at that point a stone. And then the last one, when the ureter wants to run anteriorly to empty into the bladder, it will change also its direction one more time at the ischial spine region here. So at that point also I would expect to see a stone. So these are all areas of questions. You need to know the points where you would expect to see stones, or the areas of anatomical constrictions, the pelviureteric junction, the point of the bifurcation of common iliac, and then the ureter will run with the internal iliac to get into the pelvis backward. And at the sacroiliac joint, or bifurcation of common iliac into internal and external, this is another area that we have a constriction. At the level of the ischial spine, this is another area, and at the intramural, or we call it the uretero-vesical junction. All right, so these are 4 anatomical constrictions that you would expect to see stones. For the ureters, guys, it receives blood supply from a lot of places. The abdominal one can get from the renal artery, it can get from the gonadal artery, it can get from the aorta itself. And in the pelvis, you would think about many branches, the visceral branches of internal iliac. They are also sources of blood supply to your pelvic ureter. So pelvic ureter can get blood supply from the common iliac itself, the internal iliac branch, the superior vesicle, inferior vesicle, which are the two arteries that supply the urinary bladder, from the middle rector, from the uterine vaginal. All of these can give supply to the ureter in the pelvis, and the other three can give the abdominal part of the ureter blood supply. Thank you guys for watching, and see you in the urinary bladder video. Thank you guys.